Okay, shall we start the class?
Yes, ma'am, we can start now.
Okay. How many of you are there?
48 are there, ma'am.
Okay. So, as you all know, today's topic is regarding disorders of menstruation. So, first of all, you must know how, what is a normal menstruation. So, how does a normal menstruation occur? That is when the hypothalamo-pituitary ovarian axis is functioning coherently with a normally functioning uterus and a patent outflow of genital outflow tract. So when all these three things are functioning well and they are normal with a normal karyotype, there will be a normal menstruation. So when coming to the disorders, so when any one of this factor is not working normally, we'll end up in the various disorders. So before we go into that, what is a normal menstruation? Is a normally the first menstruation will be after the menarche. So that is the first time when the girl or the girl will have the first menstruation. That is the menarche. So that is usually approximately it can happen anytime between 10 to 16 years. So this 10 to 16 years is a normal age group, which is on an average of about 12 to 13 years is an average age of menarche at present. So any menarche before the age of 10 is called as precocious puberty. So this is the normal age. So how will be the cycles? So cycle length is approximately could be 28 to 30 days cycle. That is the normal cycle. So that's a normal menstrual cycle. And this cycle should end up with a menstruation of about 5 days. So that is a normal menstruation. So anything anything abnormal apart from that is called as an abnormal menstruation. So we have various terminologies for you all to know, which is first is amenorrhea. So what is amenorrhea? When there is no periods, when there's no menstruation, we call it as amenorrhea. So this amenorrhea can even occur physiologically. When can it occur? It can occur during pregnancy or during lactation or at the end of that is or in the time of menopause. These are the few conditions where we can have a normal amenorrhea. So this is physiological. Anything apart from that is called as a pathological amenorrhea. So we will go into that detail. The next terminology I would like to talk about is menorrhagia. So what is menorrhagia? Is increase in the duration of the menstruation and also the amount of flow which the girl or woman is experiencing. So anything which is going to cause the women to have a menstruation of more than 5 to 7 days with a heavy menstruation, which is going to affect her daily activities. So theoretically, we say as like about 80 more than 80 ml of blood loss could be amenorrhagia. So both there will be increase in the duration as well as in the flow. So it is called menorrhagia. So second thing is something called oligomenorrhea. As you all know, oligo means less. So when the cycle length is going to be more than, as I said earlier, the length should be approximately between 25 to 30 days or 28 days on average is the most commonly noted one in the females. So anything less than more than 35 days. So when the patient is having her regular periods only after her 35 days, anything more than that, then we call it as oligomenorrhea. Okay, this is oligomenorrhea. Then is what is hypomenorrhea. Hypomenorrhea is something when the patient has very less scanty menstruation. Okay, so usually patients with polycystic ovary, something like that, they usually have scanty menstruation. That is like they have her menstruating only for a day or so, that too with very minimal blood flow. So that is hypomenorrhea. Then what is polymenorrhea? So polymenorrhia is patient will be experiencing frequent menstruation, like they will not have the normal cycle length. In apart from that, they will be having some very frequently, and also the cycle will be happening very early. So if she's so it will happen before a shorter duration. So she may be bleeding within 21 days. Anything less than 21 days. So that is about hypomenorrhea. So what is metrorrhagia? Metrorrhagia is something which is not related to the cycle length or something like that. It is just irregular spotting, or there is no time when she can have her. She could have her regular cycles, but in between now and then she'll be having her bleeding. So that is called metrorrhagia. So something. The other one is Menorrhagia, is like she will be having more loss, and also there won't be any regular pattern which she is following. She can bleed heavily at any time for any long, any time to any time of period she can bleed. So another terminology you must know is something called post-coital bleeding. So as you all know, coitus means intercourse. So when a patient experiences any bleeding post following her coitus, sexual intercourse, then it is called as post-coital bleeding. As I told you, precocious puberty is another terminology, which is like patient is going to have attain her menarche before the age of 10. It is called as precocious puberty. So here we will just roughly go through what are the various causes which can lead to these various disorders which we just discussed now. So as I told you, amenorrhea can be either physiological or pathological. Physiological, as I have mentioned earlier. Pathological ones we will see. And this amenorrhea can also be primary or secondary. So this primary amenorrhea is like the patient has not at all attained, not experienced any menstruation at all. So that time we label it as primary amenorrhea, and these women will be presenting to us with or without secondary sexual characters and not attained menarche approximately around the age of 14 to 16 years. So when the patient is coming to you with at 14 years but having secondary sexual characters, we can wait till maybe 16 years. But patient is presenting you with 16 plus years and not having any secondary, not found to have any secondary sexual characters, then she needs to be evaluated. So this is primary amenorrhea. And another type is secondary amenorrhea. So in this condition, patient would have been having a normal menstruation earlier, but at present for a period of 6 months or more, she has not had her menstruation regularly or not at all had her menstruation. They are called as secondary amenorrhea. So this primary amenorrhea as such itself is a very vast topic, and definitely it needs more time to discuss, and maybe not along with this other disorders, maybe we can have a brief discussion on the primary amenorrhea. So as I told you earlier, we should have a good coordinated acting pituitary hypothalamo-pituitary ovarian axis. So that should be functioning well. And she should have a normal uterus with a normal functioning ovary with a good endometrium and a patent outflow tract, which means there must be no cervical stenosis, no vaginal atresia, or she should not have any other conditions which can cause outflow tract obstruction, so that she can menstruate well. And of course, she should be having a karyotype of XX. So these are the conditions. So we will have to look into each category, and we need to find out whether why is she not attained her menarche? Why is she having primary amenorrhea? So what they have how they have classified this is, they have classified them as into 3 conditions. Like it could be hypogonadotrophic primary amenorrhea, hypergonadotrophic, or eugonadotrophic. So there are 3 conditions. These 3 we'll list the causes of amenorrhea into under these three headings. When we talk about hypergonadotrophic, so here the follicle stimulating hormone of these patients will be very high, maybe more than 40. So we have few causes under them. That is mainly we have the gonadal dysgenesis, gonadal agenesis, Turner's mosaic patterns, and all such conditions, and any resistant ovary, all those conditions will be under hypergonadotrophic amenorrhea. So we have many other causes, but I'm just briefing you on the most commonest one. Next is we have the hypogonadotrophic primary amenorrhea. So here we have things like where where there is hypothalamic factor is problem. So we can have any GnRH deficiency or any tumors there upright there in the neoplasms there in the pituitary, or it could be prolactinomas. And also conditions like those athletes and all them, or few of them who undergo severe or extensive weight loss programs and who do extensive exercises, even those people will be can develop primary amenorrhea. And apart from that, when we come to the third criteria, which is eugonadotrophic primary amenorrhea, here we most commonly concentrate on the the genital tract. So here we commonly see the Mullerian agenesis, where there could be either a simple imperforate hymen, or it could be a vaginal septum, or it could be a cervical atresia or a vaginal atresia. So it could be even when the hypothalamo pituitary ovarian axis is doing well, but patient is having an absent uterus and an absent vagina. So we call them as MRKH syndrome. So she could be one of that, and so these are the few. Or she could even be having simple causes like polycystic ovaries, or she could have tuberculous endometritis, or a common nutritional factor could also lead to primary amenorrhea in under this criteria. So we divide them into three such criteria and evaluate them accordingly. So whenever a patient comes to you, we are going to have a thorough examination right from her. How is her general build? How is her height to weight ratio? And a thorough general examination with her how is her stature, maybe a short stature or what. Then we have to examine her breast for development. Her axillary and pubic hair should be examined, and of course her external genitalia. And if it is fitting into a female genital system, then even you have to look for the outflow, whether there is a patent outflow tract present in such cases. So this is about the general examination, and we have to stage the various development of the breast and the pubic and axillary hair as per Tanner staging. So we'll get to know some information regarding that. So once when the patient is having good breast development and the well-developed secondary sexual characters, so we could assume that her estrogen levels are doing good. So there is something positive in that. So once you examine the patient thoroughly, then we have to put her onto a series of blood examinations. So it could be either after your examination, we'll have mainly it is the hormonal profile. So we have to have a FSH, follicle stimulating hormone levels, testosterone levels, her estrogen levels, and her apart from that, we have to look into the most commonest. It could be even a simple thyroid deficiency. Sugars has to be ascertained, and other hormonal factors. There are many hormones which has to be screened, and we have to have or it could be a simple GnRH deficiency, so it has to be even that has to be evaluated. So even and apart from thyroid, even prolactin hyperprolactinemia is one very common condition where we can have amenorrhea. So those things should be assessed, and of course you have to go for a further imaging if suspected for any tumors in the brain. So these are the few investigations we would be doing apart from the examination. And lastly, definitely we have to go for a karyotyping if we have a doubt about it. So so that is the few investigations to be done when a patient presents to you with primary amenorrhea. So normally, when depending upon the diagnosis you have you're meeting, we would be treating the patients according to the condition she's landing up with. So if it is suppose if it's a simple cryptomenorrhea, that is like she's having an imperforate hymen or something, we could just make a small incision on the uh, on the uh, the imperforate hymen. So if you make a small incision there, there will be a small membrane covering the outflow tract, and we could make a small incision on that, and you definitely drain out the previously collected menstruation, and she'll be menstruating in future normally. Oh, so if it's a septum which has been preventing her from menstruating, we have to remove the septum. If it is anything like an vaginal atresia or a cervical stenosis or something like that, then it has to be corrected appropriately, and we can achieve menstruation in such women. So we have conditions like AIS, that is nothing but androgen insensitivity syndrome, otherwise called as testicular feminizing syndrome. So in these patient will be typically having features of women, and even development of secondary sexual characters will be there. But as such, she will not be having a uterus or an ovary. Instead of that, gonads would be present. That could be done assessed by a MRI abdomen. So depending upon the MRI reports, we could assess the site where the gonads and has been present. And in these patients, we definitely need to remove the gonad. It has to be proceeded to a gonadectomy, or it could lead to a malignancy in such patients. So these will be presenting like women, but typically they will not be having a uterus, and achieving menstruation in them is not possible. And so similarly, we have few other conditions also. So depending upon what cause she is landing up with, and that has to be appropriately treated. Some patients we will not be able to achieve menstruation and we could only give some estrogen and progesterone supplementation for them to look like a female. That's there are also conditions like that. And so this is something relating to just about primary amenorrhea. So when it comes to secondary amenorrhea, most of the common causes, as I told you, patient would be menstruating regularly previously, but not having menstruated for the last 6 months. So such cases will be under secondary amenorrhea. So in these patients, the most commonest conditions would be hormonal imbalance. So as I said, we have to go on assessing the various hormonal factors. It could be thyroid, prolactin, her testosterone levels should be seen. She could be a polycystic ovaries that could have been developed. So these are the most commonest ones. Apart from that, as aging or previous or post any surgeries or something, like there could be scarring, vaginal atresia, cervical stenosis can also happen in some patients. Or the other one of the condition which we are encountering nowadays is like premature ovarian failure. So that could also lead to secondary amenorrhea. So these are the causes for secondary amenorrhea. So this is something about amenorrhea. So next is we'll be talking about menorrhagia. So menorrhagia, as I told you, it would be a patient will be menstruating for a longer period, and also she'll be having a excessive flow. So definitely, when this has been getting prolonged for a longer time and being present for months together or years together, it is going to affect the general condition of the mother of the patient. So when we think about the causes of menorrhagia, similarly this could be into different adolescent girls, um, and in the reproductive age group and in the perimenopausal age group we can have various causes. So in normally in women, in girls who have attained the menarche, the first few years, maybe 2 to 3 years of her post menarche menarche period is mostly is anovulatory, and they could definitely present to you with menorrhagia. So in such patients, we need to be we need to when patients presenting to you with young adolescent girls presenting to menorrhagia, the most commonest cause is physiological. Second thing, but most important one, even bleeding disorders could be manifested as menorrhagia. So we have late presentations or late diagnosis. So such patients should be have an hematologist opinion, and we have to rule out any bleeding disorders. And of course, when these causes are the most commonest causes, and we can treat them with simple tranexamic acid, or she may also require a progesterone supplement, progesterone treatment to get to reduce the amount of loss she's undergoing. So if you come to the reproductive age group, it could be fibroid polyps, adenomyosis, any other tumors, which most commonly it is leiomyomas. So in the reproductive age group, postmenopausal, perimenopausal age group can also present with leiomyosarcomas, and even she can have endometrial endometrial carcinoma. These are the most commonest in the perimenopausal age group. So how do we treat such patients? If patient has been completed their family, then very well we could go for if she's not completed a family, we have to go for conservative management where we preserve the uterus. So we can either go for a simple, uh, you know, um, hormonal treatment to reduce the blood loss. Uh, Otherwise, if we have um, the medical treatment, we have various hormonal treatment. Apart from that, if she's completed her family, and we have if the uterine size is more than 20 weeks, such she can very well go for um, hysterectomy. Suppose if the patient is having a huge myoma and she's still yet to complete her family, for fertility reasons, we'll just proceed with the myomectomy. So once the myomectomy is done, um, she can achieve her fertility very well. So this is regarding menorrhagia. So and the other conditions like oligomenorrhea, hypomenorrhea, is even these fibroid patients with leiomyomas can also present with menorrhagia or only polymenoria. So these polyps, endometrial carcinomas, leiomyomas, they all can come to you with these. They can give you a either it could be they could present with menorrhagia, they could present with menorrhagia, or with polymenoria, or even an intermenstrual bleeding. Whereas these oligomenorrhea, hypomenorrhea, these conditions are more commonly associated with the hormonal imbalance, like PCOD, hypothyroidism, prolactinomas, hyperprolactinemia. So these are a few conditions we have to keep in mind when we're treating patients with um, these conditions like oligomenorrhea or hypomenorrhea. So once you have diagnosed any hypothyroidism or hyperprolactinemia in such patients, treating the condition will definitely resolve the problem, and they could have a regular and normal menstruation. Another most commonest is polycystic ovarian. So in these patients, polycystic ovarian patients, apart from the treatment, most of them will be overweight or obese. So these patients definitely a lifestyle modification and regular exercises with good diet and weight reduction will definitely be required for her to achieve regular menstruation, along with the other medication she's going to be put forth for a polycystic ovarian. So when you have patients with polycystic ovarian syndrome, so definitely we need to have a check on her sugar levels. So she could also be a diabetic. So definitely have a check on her sugars and try to correct her sugar levels also. So definitely after doing these things, she could have her cycles regularly. So in brief, we have discussed about primary and secondary amenorrhea and the other menstrual disorders which could be encountered in patients in various age groups. So whenever we have patients in a younger age group with bleeding disorders, think in terms of either it could be physiological or it could be the first presentation or a first time to diagnose a bleeding disorder which was missed all this while for that particular patient. And whenever we have patients in the perimenopausal age group presenting to you with bleeding disorders, with abnormal menstruation, always think of malignancy. So the first diagnosis will be malignancy. When we have patients, first one of your differential diagnosis will be malignancy, not always malignancy. And we have patients with the reproductive age group. This is the most benign conditions like myomas and adenomyomas, endometriotic cysts, and it could even be a tubercular endometritis, which has been causing either amenorrhea or irregular spotting. So patient can have different presentations for different conditions. So this is the take-home message for today's class. Okay, so I think we will end our session with this. If you have any doubts, you can ask me. Can we close the session?
Yes, ma'am.
Okay, thank you so much.
Thank you, ma'am. Others don't.